Welcome to the Low Carb Conferences podcast. I'm your host, Dr. Jeff Gerber. Our special guest today is Dr. Abby Bleistein, who will be speaking at our conference in February next year. How are you today, Abby?
I'm doing great. How are you?
Doing well. We were trying to have this podcast in person since you're a local here in Colorado, but because of your busy schedule seeing clients, we weren't able to pull that off. So maybe next time, huh?
Absolutely. That'd be great. Yeah.
So yeah, a little bit about Abby. She's a physician who is board certified in internal medicine, pediatrics, and obesity medicine. She's the owner and founder of a multidisciplinary obesity medicine practice called Healthful Life MD, and also provides care for individuals at the Eating Recovery Center here in Colorado. She has a particular interest in eating disorders and has lectured on the topic in the past, and we'll be discussing eating disorders at our conference in February. So Abby, if you can provide a little more background and share with us your personal and professional interests.
Yeah, absolutely. Well, thank you. And thanks again so much for having me. I'm looking forward to the conference in February for sure. But yeah, so I am a physician, as you mentioned, board certified in internal medicine and pediatrics and also in obesity medicine. And I practiced in primary care for about 15 years before I started kind of changing the focus of my practice. And I certainly loved primary care. But I found that I was having less and less time to spend with patients, and the numbers were sort of becoming a struggle for me, and was introduced to obesity medicine by a friend of mine. And it's interesting because at the time in my practice, I was starting to see kind of more and more diseases of what I call diseases of nutrition, right? So things like fatty liver and things like diabetes, and even in patients who were not, who didn't carry significant overweight, right? And so it was really interesting to me as I was seeing some of these changes in practice, along with kind of talking to, my colleague and friend. And I went to the Obesity Medicine Association board review and conference that spring and just got really excited. It was kind of the first time I was excited about the science of medicine in a long time. Just really fascinating talks about metabolic disease, about nutrition, about exercise and fitness, and just psychology. Everything really was just fascinating to me. And I was able to bring that back to my primary care practice. And what I found is I could not practice the way I wanted to practice, sort of in a standard, medical practice. Just it was too busy. I didn't have time to give to people. And I felt that I wanted a multidisciplinary approach. So that's shortly after that conference, really, where I started thinking, I need to start my own practice. And so my practice, the focus was really on sustainable lifestyle change, right? Because as you know, there's lots of ways to help people lose weight, variably successful. But the reality is we don't have the magic around how do we help people sustain the weight that they lose. And so my goal in practice and what I really focus on is how do I help people with sustainable lifestyle change? How can they not just lose weight, but really live their best lives and thrive, kind of keep that weight off and be healthier at the end of the program than they were at the beginning. And so that's really been my focus and practice and what I developed at Healthful Life MD.
Well, great, Amy. I discovered the Obesity Medicine Association back in 2005. It had a different name back then.
Yep.
And, it's a great organization, and we like the group because they're really independent thinkers and trying to get away from the traditional medical model of just prescribing. And so
Absolutely.
the idea is to help people through lifestyle and to improve their health, and also de-prescribing if you have success.
Exactly. Yeah. So,
Well,
and I think,
so you've been helping patients, and I love that you're a clinician like myself. And I might ask that you also developed an interest in eating disorders, and where did that come from?
Yeah, so that's interesting. So a few years ago, actually, right around the beginning of the pandemic, I started working in addition to my own practice at the Eating Recovery Center, which is a residential treatment center for patients with eating disorders. And actually, they have adults and kids that they see both. And I work with the medical teams as part of that group. So taking care of medical problems associated with the eating disorder for the patients in residential care. And it was a great addition for me because it really I don't want to say introduced me to, but really broadened my knowledge and understanding of the issues of eating disorders and how patients are really affected by eating disorders, and changed my own practice a little bit in terms of really trying to identify eating disorders in my practice, because patients are not going to live well if they're struggling, with eating disorders. And so really working with patients on identifying if that's an issue and then helping them work through that as we go through the program.
Yeah. So how is it that the associations recognized your interest in eating disorders, and you've been out on the lecture circuit? How did they find you?
Yeah, so I've been actually with the Obesity Medicine Association for quite some time, and so almost since that first board review that I went to, that I attended. And so actually I work with the advocacy committee with them, and I'm also the STARS representative for Colorado doing obesity medicine advocacy. I was part of the pediatric committee with them as well, and suggested a talk, so a few years ago on eating disorders, and have been kind of called back to do a couple of other, talks on that, as well as their board review. Let's see, last year, 2021. I did the board review on psychology, behavior, and eating disorders.
Great. So it was actually our friend and colleague, Heather Fritz, who had heard you speak at one of the recent conferences. And she knew that I had an interest in bringing the eating disorder topic to our conference. And she had recommended that you would be a great addition. And so here you are. We're really happy to have you.
Yeah, and I'm happy to be here. Yes, and I know her also from Eating Recovery Center. But yeah, so she's seen the talk, and one of the talks that I did. But I do think it's such an important issue, because I feel like among the things that as physicians we don't get much training in, I don't think we get a lot of training in eating disorders, recognizing them, and it's because of the shame that's associated with eating disorders. I think patients really don't bring it up, and so if we don't ask, they're not going to tell, and they're not going to let us know about it. And so, really the exposure and the work that I do there has helped me to really recognize, learn how to talk to patients about this, ask them about it, and that kind of non-judgmental approach that, to help them understand what's going on with them, and that they really can get help for it.
Yeah, so you brought up the issue of shame, and that's an issue. And I would also add that not only we don't learn a lot about eating disorders, but we don't learn a lot about nutrition. And so, we kind of took it upon ourselves, and then we have the obesity societies that have helped out. But it really leads to kind of the next thing that I wanted to discuss with you. And because we're in this unique position where patients are seeking our advice to live healthier, address nutrition, lifestyle, and weight loss, it kind of opens up the door for us to ask sensitive questions. Don't you agree?
Yeah, absolutely. Yeah.
Yeah. And so along those lines, the reason I wanted you to come and speak at the conference is because eating disorders, to me, is the big elephant in the room, rather, in a conference, in a doctor's office. And if you're not addressing eating disorders, you're really missing the mark. And so both in our office and at the conferences, but this will be our 6th year having conferences, and we promote better lifestyle, health, and nutrition. But I often worry about the audience, that there are indeed people with eating disorders out there. And
Mhm.
in a sense, the conference is enabling them with a new approach that they can abuse.
Yeah.
And so the idea, and perhaps you could talk a little bit more about this, is, how does the approach change when you first have to determine if a patient has an eating disorder, an individual, and then how do you approach that individual?
Yeah. And so, we think of the gamut of eating disorders, right? There are eating disorders where patients maybe are really underweight, and then eating disorders where patients may, carry extra weight, or anything in between, right? And so we don't know just by looking at a patient's weight, whether or not they have an eating disorder and what that eating disorder might be. And so one of the things that's, I recognize and that my colleagues talk about quite a bit in terms of patients who are underweight or losing weight, is that there are patients who have significant eating disorders, but if they're losing weight, or if they're actually even underweight, they get lots of kudos from their physician for, hey, look, you lost all this weight. That's great. And the docs really kind of praise them without ever taking a step back and going, wait a minute, let me hear more about what's going on and what's happening here. And so we're less likely to recognize that patient who's underweight or borderline weight, or maybe who lost weight so quickly because of disordered eating, because we just, because we're prone as providers to sort of say, oh, weight loss is good, you don't carry extra weight, you don't have obesity, you don't have overweight, you must be healthy. And the reality is that patients may not be. And so, and on the other end of the spectrum, with sort of loss of control eating or binge eating disorder, those patients may not all be overweight. So patients may have significant struggles with loss of control eating and may not be overweight. And so, it's easy to miss that as well, that patients are really struggling. And then as you're telling them, here's what you need to do to lose weight, you may actually be suggesting things to them that are very triggering or could worsen the eating disorder, and they may not be as successful as they could be if you recognize the eating disorder. So so I think recognizing it is really important in practice, and there's lots of reasons why we may miss it as well.
Sure. And again, as you say, as a provider, in the realm of addressing health, nutrition, and diet, you're really doing a disservice to your clients if you're not screening and you don't recognize that there is a particular problem. So, for instance, as I promote low carb nutrition, and we
Yeah.
have a lot of patients that come in to see us because they had heard about our focus, our conference, and they want us to put them on a low carb, a high fat diet, a ketogenic diet,
Yeah.
intermittent fasting. And you say, oh, sure, we'll throw this down your throat. Let's do extended fasts and don't eat carbohydrate. And how dangerous can that be for somebody with an eating disorder to throw this right at them?
Yes, yeah. And so depending on the patient, it really can actually exacerbate the eating disorder. And so, for a lot of eating disorders, kind of structure around their eating and scheduled eating can be really important. And if you put people on, say, an intermittent fasting plan, just as a standard of practice, you actually could end up really triggering patients that really need a different structure, right? And so if you tell people, well, don't eat until 10 or 11 in the morning, that could really, someone with binge eating disorder, that restriction can end up triggering those behaviors. And someone who with anorexia may find that like, well, I can restrict all day. And if restricting, till 10 is great, then maybe restricting till 3 is better, and one meal a day. And so you can end up really exacerbating and triggering their symptoms of the eating disorder. And similarly with a meal plan that for a lot of these patients, the structure of the restriction feels very safe. And so patients with binge eating disorder, that kind of structure of a low carb plan makes them feel a little bit safer because there are things they can't eat, and and so they try to feel as if putting it in a box can be helpful or will be helpful. And the reality is that if they are if they struggle with it and feel that they're not successful, that really can trigger kind of binge urges and binge behaviors. And similarly, patients with anorexia, the restriction, they really look to more and more restriction. And so changing that eating pattern to a very restrictive plan feeds into the anorexia and will exacerbate those symptoms. And they end up needing more and more and more of the restriction. And so it really can exacerbate those symptoms when you have something really restrictive like a low carb plan, and so understanding where the patient is coming from and what their triggers might be, I think are really important, because, you really can fall into that. And one of the things I think about too, I had a patient once who came to me and he had been on kind of a low carb program before. And so he came and we were talking about the nutrition plan. And he said to me, well, can I eat carrots? And I said, well, of course you can eat carrots, So he was living in this world where eating a carrot was a very negative thing. And it was interesting because his eating behaviors then, when he sort of went off plan, he was way off plan, right? So he was eating out to, and getting kind of Asian food all the time and eating rice, eating other things. And, and so he was avoiding carrots. But then he ended up sort of overeating or binging these other foods that you would consider sort of off plan for a low carb plan. And so the message kind of gets distorted, in the thinking, if you have eating disorders, one of the key features of it really is this distortion of reality to a certain extent. And so, so you can kind of see where it can go down this line where patients really can start to, distort the message and really disrupt their eating. And it could lead to things like, orthorexia, which is kind of a form of anorexia restriction, where their rules around eating have to do with what they believe is healthy, a healthy eating pattern. And, so we have to be really cautious and pay attention, to how patients maybe are interpreting some of the structure around their nutrition plan.
Yeah, so I call the people that have orthorexia, they're food snobs, and maybe for better or worse. But it's interesting. So some individuals need more structured programs where others don't. But I think if you identify an eating disorder, it adds a layer of complexity to your approach to the patient. And
yes.
And so I just want to say, just for the sake of conversation, I talked about putting everybody on low carb, high fat ketogenic diets, and that's certainly not what we do here. That was just illustrate a point. We try to be very sensitive, and we realize that everybody's treated differently. And so,
absolutely.
Might I ask, how do you screen for an eating disorder?
Yeah. And so, in my practice, I actually screen everyone for disordered eating because I feel like they are high risk. There are some studies that show as many as like 30% of patients who are seeking care for obesity actually have binge eating disorder. So that's a pretty significant proportion of patients who are coming in to see me. So I actually do what's called the binge eating scale, which is a questionnaire that patients can fill out that looks at 16 different questions regarding loss of control eating and those kinds of behaviors. Some things around emotional eating and stuff as well, but mostly, that's for binge eating. And then I also do what's called a TEFQ 18, and it is an eating disorder questionnaire that looks at behaviors associated with restriction, that looks at emotional eating and then looks at binge eating as well. And so I can kind of get an idea of whether, patients are kind of in that direction. So all of my patients that come to me, they do that screening before I even see them. But really the best way that you can get an idea of what's going on with patients is to ask the question, right? So when I'm seeing them, so I may have an idea looking at this screening that, wow, this may be binge eating disorder. Then I can kind of talk to them about it. So the kinds of things that I might ask a patient, particular patients with obesity is, have you ever felt out of control with your eating, or do you ever eat until you're overfull? And patients can kind of answer that. And then I can kind of dig deeper, oh yeah, I've done that. And like, well, tell me more, how often is that happening? And when does it happen? And describe. And so then I can kind of get an idea of how much are they eating? How often is it happening? So binge eating disorder, of course, to meet kind of DSM-5 criteria, which is how we make those diagnoses, they have to be doing it 3 days a week for a certain amount of time. And so, so we can kind of see, is there just some loss of control eating episodes, or is it really the diagnosis of binge eating disorder? But the other thing that I start to ask patients as well is, so they might describe this loss of control as, I might say, have you ever purged? Right? Have you ever purged or used diuretics or used laxatives inappropriately? And it's really interesting because when I didn't ask that question, it wouldn't come up. But when I do ask it, it does come up. I have a history of purging. I haven't done it in a year, or I haven't done it since I was a teenager, or maybe I'm actively purging, a few times a month. So tell me, how often is that happening? What does that look like? When we think about purging with laxatives, what really surprised me as I started doing more work with Eating Recovery Center is the extent to which patients might be misusing these medications. And so patients might be using a box of laxatives a day, right? Like 40 or 50 pills a day, which just really surprised me. And imagine the suffering and the struggling that they're going through, to be doing that to themselves and to their body and what happens. So, so asking patients about kind of purging behaviors. And then I'll ask patients, tell me about restriction. Do you ever feel like you restrict your nutrition? And what does that look like? Right. And so really getting an idea of what that is. And patients, with binge eating, they might say, oh, I'm just not hungry in the morning. But then if you say, well, tell me about your restriction. Well, I try not to eat and I try not to eat. And then 3 o'clock in the afternoon, I get hungry. And then maybe they have this grazing pattern where they just eat and eat and eat through dinner and then into the evening. And so you can start to get a better picture about the kinds of behaviors that they're having. And remember too, as you're asking these questions, patients might not recognize it as a eating disorder or disordered eating, right? And so when you get the picture of what's going on, they may not say, oh, I have this, I have an eating disorder. But patients are really surprised when I say, wow, that sounds a little bit like loss of control eating, or that sounds a little bit like binge eating. What do you think? And so, and then we can kind of start to talk about that in more detail.
Excellent. And so I agree. Once you warm up to the patient, it's your right as a provider to really ask these questions. And, I always start out, do you have a bad relationship with food? And I usually the eyebrow lifts up and they say, well, funny you should ask. And let's talk about that a little bit more. And I actually had a patient this morning, a new patient, and I encouraged that patient to have a listen to the podcast. And that patient really fits into a lot about what we're discussing today. And to the credit of the patient, I think the patient in this particular situation has a lot of insight already as to what the issues are. And it was revealing to me after, we had met that we have to address these issues. But as you said, there's some people that come in and, they have no idea at all what is going on. But, I wanted to bring this up. I may have mentioned this to you before, but there's a pattern that I've noticed. Obviously, you know more about this, but when you start to dive into the history, I've actually had a couple patients that have some common themes in
Mhm.
their history,
Yeah.
and that is of child abuse,
Mhm.
depression, anxiety,
Yep.
attention deficit disorder,
Yeah.
addictions of all kinds, both food
Mhm.
and drug, and
Mhm.
then they come in to see us, and
Yeah.
so there's this pattern that I'm seeing over and over again, and I was wondering what you thought about that.
Yeah, yeah. And so one of the other screening tests that we do, or that I do in my practice at Healthful Life, is is we screen for what's called ACEs, or adverse childhood experiences. And the ACEs screening, if people aren't familiar with it, looks at 11 different adverse childhood experiences, from from abuse to parental uh, violence, so domestic violence, or living in a household with domestic violence, a parent who has a substance use disorder, food insecurity, things like that. And so the ACEs questions really kind of look at those things. And what's interesting is the ACEs itself, the Adverse Childhood Experiences survey, actually came about as a result of an obesity medicine specialist recognizing that so many of his patients had these kind of adverse childhood experiences. And so we sort of developed these questionnaires. And as it turns out, probably somewhere around 80% of patients with binge eating disorder have had, one or more adverse childhood experiences. So I think it is a pattern, that we see, and it's good to recognize it. And what's important is, in practice, is that we have trauma-informed care, right? Recognize that these patients that you're working with probably have suffered from some kind of adverse childhood experience or some kind of trauma. And of course, those things are also associated with depression and anxiety. And certainly depression and anxiety are more common in patients with binge eating disorder. Substance use and ADHD are also more common in patients with binge eating disorder as well. Patients with anorexia tend to have, anxiety disorder is really common in those patients. They also have oftentimes have trauma history, adverse childhood experiences as well. Then an OCD is more common in patients with anorexia, whereas patients with binge eating oftentimes have ADHD. So it's interesting that we sort of see those things. Patients with bulimia, oftentimes that can be associated as well with ADHD, but also anxiety and depression. So we see all of those things kind of connected for sure.
Yeah, so obviously they're connected, and the writing is almost on the wall if you pay attention to it
Mhm.
when the individual comes in, and so it is really important to address all these aspects. Another interesting thing that I've noticed is that you know you treat ADHD with medication that
Mhm.
also addresses um, uh, bulimia and binge eating.
Yeah,
So,
yeah,
so there
yeah.
must be some of the same neurochemistry going on in the brain there.
Yeah, and it really is. And so that's, so I think that's really interesting that we see that. And, and treating, my patients who have ADHD and binge eating disorder both together when I've treated with those medications is incredible. The difference that it makes in them, and it can be life-changing. And so they sort of talk about these intrusive, what I call intrusive food thoughts, right? So people who feel like there's just always this mental chatter about when is my next meal, what am I going to eat? There's somebody's birthday, and in the break room there's a cake, and they have this kind of cake going all the time. And suddenly with this medication, it turns that off, and it's such a dramatic shift for these patients when it works well. It just, it's life-changing. I had one patient say, now I understand what normal people, normal in quotes, what she says to me, what normal people feel like, because she had been struggling with this. I worry about when is my next meal going to be, and not having it and not being able to get to her next meal in time. And it just sort of went away, and it just was so freeing. So the mental energy that is tied up in eating disorders and disorders disordered eating, it's exhausting, right? And so really trying to work on it, and have it get better, really, it just really changes people's, experience in life, right? It just, their quality of life really improves.
Yeah, so certainly in the right context of support, nutrition counseling, medication can sometimes be quite beneficial. And,
Mhm.
in a sense, again, it is complex. There's a lot to it. And, that's why you have a multidisciplinary approach. And
Mhm.
not all of us have access to that. And so, I would encourage, if you have a patient or a client that comes in with concerns about eating disorders, that you take a multidisciplinary approach, and you get help from either inside your office or outside your office.
Yeah, absolutely. And that's really one of the reasons, that I really went to that approach with multidisciplinary team, because I feel like it's a very complicated issue. And so to have those specialists in each area really benefits the patients, and I think improves outcomes long term. So I have a nutritionist and a dietitian that I work with who are familiar with these kinds of issues, but I also have a psychologist in my program who's a certified eating disorder specialist. And so patients who are coming to me for weight loss who may be struggling with binge eating disorder, we want to treat the binge eating disorder at the same time. And occasionally the binge eating disorder becomes the priority. And so we really need to treat the binge eating before we treat the obesity. And so having them work with her, at the same time or ahead of time can really make a big difference, and and how they're living their life. And so I think that really helps. And our program has a trainer as well. And so that's helpful, for lots of things in terms of overexercise. We think about some of those things, and she can help us in that realm as well.
Yeah, well, you're rapidly becoming one of my favorite doctors in town, and I,
Thank you.
I have been and will continue to send patients your way,
Yes, thank
because
you.
again, there is complexity when it comes to the eating disorder issue.
Yeah, yeah,
And so, the approaches to treatment, we talked a little bit about it, but I just like to emphasize that the approach is not necessarily different for someone who wants to lose weight. It's just you have to be sensitive to these other complex issues, and the idea is to go slowly. I don't like the idea of just shoving something extreme down the patient's throat. And in fact, the patient today, we discussed that it's an all or none phenomenon, that
yeah,
the
yeah.
person will be on track, will be on the wagon and then totally fall off the wagon. And the
Mhm.
words were, I need an approach that is lifelong and slow and steady. And so I like the baby step approach with these individuals.
Yeah, yeah. And I'll talk about this more in my talk in February as well. But when we look in particular with binge eating disorder, although it applies to the others as well, we can actually think about what I call a phenotype of the eating disorder. And so, not everyone with binge eating has the same the same appearance or the same struggles. And so really trying to identify, is this more of a trauma related issue, or does this look more like addiction? And that's two different things. And we actually would treat it in two different ways, right? So a patient with addiction probably needs more structure and maybe more restriction, whereas a patient who has trauma history, that restriction is actually going to be quite triggering, right? And so we can get into that more in my talk, but it's really, you can actually refine the treatment plan more carefully by talking to the patient more about their history, what their symptoms are, what's triggering, what isn't, and then creating a plan around their needs, because of that. So I think that's important as well, to kind of look at the patient as, all patients are individuals, right? And so really coming up with that individualized plan around what their needs are, I think is important. And we end up, I think, having them be more successful, if we can really understand what's going on.
Sure. Well, it'll be great to hear more about that. So, I guess one last thing that I wanted to talk about, and certainly you can bring up any other topics you wish,
Sure. Mhm.
but I've actually looked at your website and what you do, and you don't really mention a particular dietary approach.
Mhm.
And so my question is, are you a agnostic when it comes to nutrition, meaning that you're open up to any particular approach, perhaps, but are there some general themes when you're considering an eating disorder in terms of, the types of foods that an individual should think about consuming or not consuming?
Yeah, yeah. So I think, in weight loss, we know that, eating lower carb is probably better, right? You're going to do better on a lower carb for weight loss. And it's interesting. I think that we could question with our new data and new information. We can kind of question what is low carb and lower carb, and what does that mean? What's normal carb, right? And perhaps what most people are eating is not actually normal carb, but it's high carb. And so I think that we have to sort of, look at those things. So when I'm thinking about treating obesity, what I know is that, carbohydrates matter, right? And I also recognize for health that sugar and excess sugar can really wreak havoc on our bodies and in lots of different ways, right? And so I recognize that as a physician, that wow, these things are probably not great for people in general. So that's kind of where I would lead patients. But what I find in practice, or in my practice anyway, it's not sustainable. The really ketogenic diets for most of my patients, it's not sustainable long term. Now, I have some patients who come in and say, I feel great. I want to eat, the ketogenic, and they feel really good on it and it works for them. And so that's great. But a lot of my patients really, it doesn't work for them long term. It's just not sustainable. And so, so my approach tends to be more moderate. And I also tend to take an individualized approach on nutrition in general. So some patients may come to me and they might have sort of a vegan eating pattern, and they want to do that for, sustainable, I'm going to say sustainability, but I mean for the environment, or for moral reasons or whatever it is. And so, I work with patients within that to create a healthy eating pattern around that. So there's certainly rules, I don't want to say rules, but there's certainly guidelines around nutrition that we know are going to be healthier for our bodies long term. But I think jumping into a very restrictive plan for some patients is not going to be really helpful. So I really try to be cognizant of where the patient is at. And some patients come in feeling like, I want you to tell me what to eat, exactly amounts and whatever, and want something very prescriptive. And they may call back and go, this is really, it's not working for me. I don't, whatever. It might be triggering, it might be a problem. And then we can say, well, let's change what we're doing, right? And so having flexibility, giving patients that opening and permission, if you will, to say, this is not good for me. This isn't working well. Let's try something different. And then we can kind of restructure things around what might be more sustainable or supportive for them. So, so I have the ability, fortunately, in my practice, that I can have very individualized care and have lots of touch points with my specialists, so we can start to recognize that they didn't hear us right, or that may be triggering for this patient. And that all or nothing thinking that you're talking about, right? A lot of patients struggle with all or nothing, right? They're on or they're off. And so really trying to work patients away from that into something that's more sustainable, and helping patients understand what's realistic and what's going to help support them better long term.
Sure, Abby. Well, look, I certainly agree that cutting back on carbs, because of, how it affects metabolism and it can drive appetite, But, to kind of push your buttons, maybe it's not the carb content, but the processing of the food.
Absolutely.
Eating candy bars and things like that that are manufactured to really trigger the reward centers of the brain. You know, maybe that's the problem and not that it's carbohydrate.
Yeah. And so you look, if you look at the data around that, which I think is really interesting, but sugar, like I said, sugar is really problematic, and the processing of the food. If you look at at research around food addiction, what they call food addiction, what they find is the most addictive foods are a certain ratio of carbs to fats, right? And so it's that ratio that actually seems to be most addictive to people. So it's triggering those pleasure centers in the brain. And so if you think about, you can imagine what the most addictive foods are, but really, so cookies, popcorn, pizza, all these things that people really struggle with are actually, found on in studies to be the most addictive foods. And I think, if we look at the work of like Robert Lustig, he's done a lot of work around changing, from sugar to a different kind of carbohydrate source. And it's interesting how quickly the metabolic signs change. So the markers of inflammation, cholesterol, insulin resistance, within weeks actually improves if you get people off sugar without changing how much carb they're eating at all. And so I think you're right that if we look at sugar content in food, if we look at processing, patients actually will do much better as they as they change kind of their eating patterns. And I'll tell patients that as well, that, our brains are set to crave what we eat most often. And so I say, I promise you, it's hard initially, but as you start to eat more vegetables and stuff, then your brain starts to crave it. And so as you change your nutrition pattern and change what you're doing in general, that really does change in your brain. So definitely, eating patterns can impact, people's cravings and hunger, in lots of ways. But I would agree with you that, processed foods certainly can exacerbate that, right? And they're made to want you to eat more, right? That's how they're designed.
Well, yeah, great, Abby. Heather has shared with me that, traditionally, typically in eating recovery centers, they let the people eat whatever they want. That includes candy bar and chips. And that just blows my mind. How can that be? I mean, the goal to me is, as you said, to clean up the diet in terms of eating whole unprocessed foods. That's got to help.
Yeah. And so, how we might treat patients with anorexia and bulimia is going to look a little bit different than how, and really needs to look a little bit different than how we would treat someone with binge eating disorder. Or, for example, we've had patients there who have had bariatric surgery, and really because of what's called dumping syndrome. So patients who've had bariatric surgery, if they have too many carbs, it leads to what's called dumping, and they have terrible diarrhea. It's very upsetting for their system and their stomach after the surgery. And so to say those patients can eat whatever isn't, that's not probably safe or healthy for them. And so I think we have to look at those patient populations very differently, right? So patients with anorexia who are struggling around restriction, having permissive eating and really addressing what almost looks like a phobia. If you're kind of to look at similarities between the types of struggles, right? That exposure is actually helpful, and really helping them to overcome that restriction makes a really big difference, because patients with anorexia have a lot of food rules and fear foods, what we call fear foods, that they just can't eat. And it really exacerbates the disease process, because they, because they get the pleasure centers, if you will, with patients with anorexia, really get triggered by that restriction rather than the eating. And so
Wow.
for those patients, that exposure is going to really be beneficial for them. Patients with binge eating disorder, some patients may actually be really triggered by restriction, in which case, we want to treat with what I call a permissive eating pattern. So we need to kind of learn that it's okay to have these foods. You don't have to say, I can never have this, right? So you can have, this permissive eating pattern and then start to tease out, do I really want this, right? Is this a binge urge? Am I hungry? Or is this an emotional hunger that I need to feed? And really working with patients on, kind of coping skills and, and identifying what it is around that need that they have or that they want. And so for some patients, that having permissive eating can be helpful for them. Other patients, like I said, actually do better if it looks more like addiction, where we have more restriction. And so we have to look at the patient specifically to see how they do with that. But, a patient who's had bariatric surgery or a patient with diabetes, right? There are foods that are really going to make them sicker. And we have to recognize that and help them through that, right? And we've done with some of my patients, and certainly we do this in the Eating Recovery Center, that we do, supported exposure therapy. So for some patients, there might be specific foods that are triggering for them. So pizza, for example, can be very triggering. And so patients, that's their go-to when they have a binge urge, they need pizza and they eat pizza and they really end up overeating the pizza and feel the loss of control and the shame and everything that goes with that. And so we can have them with our, with the therapist, actually get pizza and eat the pizza with the therapist and work on that trigger. And so that sort of supported exposure therapy can help patients identify and understand what's going on with them, that they have, that's a trigger food, and how can we overcome that so that they can feel like I can have pizza whenever I want, but maybe I don't need it, right? And suddenly it becomes a different process, right? Do I want this, or is there something else going on? And then we can recognize those things and really live healthier as a result.
Yeah. So, wow, that's a lot of information you provided.
It's a lot. Yeah, sorry.
I just want to repeat that you were discussing different types of patients, but with anorexics, they get more reward not eating than they do eating. And so you have to change that pattern, giving them permission to eat. And in that sense, they can eat, sometimes they can eat whatever they want. It's just to let them know that it's okay. So that's great, Abby. I mean, I'm learning here as you're speaking. So, it's great. It's great that we're having this conversation today. And again, it's great that we're going to have you at the conference. So, I think we probably used up our time. How can the audience find out more about you and what you're doing?
Thank you. So my practice is called Healthful Life MD. So health, HEALTH. People don't always understand when I say that, but Healthful Life MD. And I'm in Golden, Colorado. You can find me. The practice is certainly on the web, so you can find our website. And I actually do free phone consultation with patients. So if you feel like you have a patient that you'd like to refer, or if you are someone who's struggling, with your weight or with your relationship with food or anything like that, I'd love to see you at our practice, and I'm happy to have that phone call with you so you can learn a little bit more about whether it'd be a good fit. So yeah, that would be great.
Great. And so again, Abby will be speaking at our conference in February, and we encourage everyone to attend, the general public and healthcare professionals. If you want to learn more about our conference, please visit lowcarbconferences.com. So that's all for now. Again, thanks, Abby, and we'll catch everyone next time.
Sounds good. Take care. Bye-bye.